Next due, the Plenary 8, an enlightening session on the emerging role of endoscopic combined intrarenal surgery for the upper tract urolithiasis will be chaired by Dr. Suren De Silva, the immediate past president of Sri Lanka Association of Urological Surgeons, and Dr. Prabhat Patiratna, consultant urological surgeon. Over to you, sir.
The next item on the agenda is the SAUS Association of Urological Surgeons lecture. Emerging role of endoscopic combined intrarenal surgery for upper tract urolithiasis. Professor Madhu Agrawal, President of the SAUS Association of Urological Surgeons, will be delivering it. Dr. Agrawal needs no introduction. He is no stranger to Sri Lankan neurology. He has contributed so much for the training of SLAUS members for many years. It's all yours, sir.
Well, friends, it's a pleasure for me to join you again. And my subject for this talk is a combination of the previous debate. So we have debated between the role of the PCNL and flexible ureteroscopy, and I have an offer of combining the two. So that is ECIRS, or endoscopic combined intrarenal surgery. This is my disclosure slide. Now we all know that urolithiasis is extremely common in our part of the world, the entire South Asian region, including Sri Lanka. And many of us, the urologists, are busy taking out stones, which takes almost half of our practice. And we have been struggling with stones, and this is a list of the procedures available for removing stones in a kind of order of their invasiveness and possibly effectiveness. And the newest kid on the block is ECIRS, which lies somewhere in between in terms of invasiveness. But I think it is probably one of the most effective modalities because it allows you complete access to every part of the urinary tract because of the combined approach. Now, going back to the history of PCNL, we all know that percs were introduced in prone position in the 1980s, but it is interesting to note that soon after, supine PCNL was introduced by Valdivia. However, it did not gain popularity for many years, and the natural question is why? Possibly because it did not seem to offer significant advantage over prone PCNL, in addition to having some rather restricted field available for access because of the supine position. However, things changed when the supine position was modified to allow retrograde access simultaneously. And the credit goes to Scoffon and his team, who introduced what has been called the Galdeco modified supine position. And this allowed access from below as well as from above. So combining what our two friends, Anil and Balagobi, presented to you a little while ago, the flexible ureteroscopy and the percutaneous approach together at the same time, giving you the best of both worlds. And by this approach, the position of which you all know well enough, the only, I think, limitation you can say of this is that it requires two teams of surgeons, assistants, and two set of instruments, everything doubled, making the entire OR setup a little bit of overcrowding, but still, I think it is worthwhile because it takes you a few extra minutes setting up the patient, but the time taken in turning the patient prone is compensated because you do everything in supine. It can be done fluoroscopy guided and ultrasound assisted with fluoro, of course. And when you do fluoroscopy guided, the fluoroscope is used not like turning the C-arm 30 towards you, but turning the C-arm cephalad or caudad, just as like we do in ESWL. But I think personally that supine PCNL or ECIRS is where ultrasound is extremely beneficial if you combine it with fluoro guidance for puncture, because it allows you clear real-time evaluation of the kidney, differentiation between posterior and anterior calyx, which is in any case very difficult in supine position with fluoro alone, and on top of everything else, it cuts down on radiation exposure, which is very important in any busy endourology unit. And if you have a puncture guide with your ultrasound probe, and preferably a small probe head, and now we have these eco-tip needles, and this makes the puncture very comfortable, very easy, almost fluoro-free. And once you've got the puncture, then of course, we all know that in PCNL, the puncture is the most important thing and the rest of the battle is easily won. So you can see that under fluoro guidance in supine position, making puncture is a child's play actually once you get to use it. And the world over, more and more people are now switching to ultrasound guided puncture. And in our country, in India, and I think in most of the South Asian countries, thankfully, it is the urologist who does his own puncture, not depending on the radiologist, which is, I think, is a great boon. So all of us need to, and if you don't have restrictions like India about acquiring an ultrasound in your OR, I would very strongly recommend all of us should go for ultrasound guided punctures. So we published many years ago the benefits of ultrasound as we saw it in improving accuracy, in reducing morbidity, and of course, reducing the radiation exposure. But there have been multiple studies, publications in literature attesting to the safety and efficacy of ultrasound-guided puncture. You add Doppler to it, and that makes the ultrasound guidance even better, because then you can even avoid injuring any vessels that come on your way. And in supine PCNL, PCNL and ECIRS, you can put in a flexible ureteroscope, watch the puncture going through the exact papilla, and you can do actually a completely fluoro-free PCNL also, because you can watch the dilatation and putting in the implants under vision. So you can dispense with fluoroscopy altogether. And some of our Chinese colleagues are doing just that. But what has helped reducing the morbidity, and just like Dr. Balagopi mentioned earlier, in PCNL and in ECIRS, is miniaturization of the tracts, as we all know. And for many of us, mini PCNL has now become the standard of care. I don't remember when was the last time I took up the 24 or 26 sheath, employee sheath. We do even staghorns with mini perc nowadays. So combining flexible or for upper ureter, you can even use a rigid ureteroscope with supine mini PCNL with ultrasound guidance, makes it a near perfect way of approaching the entire urinary tract, bloodlessly, safe, and with perfect accuracy. And this is an example I'm showing you of impacted large upper ureteric stone, which is a perfect case for ECIRS, because if you were to go from below, the stone will slip back into the kidney. Impacted stone, you have to fragment it, and even a flexible ureteroscopy is challenging. If you go from above, you will be stuck, and the angle can sometimes be very challenging. So you make a puncture under ultrasound guidance, you watch the tract dilatation under retrograde endoscopic control. So you do an endoscopic guided and ultrasound guided puncture, tract dilatation, and you can achieve complete clearance in no time, nearly complete bloodlessly. And you can watch from your, you have dual control, 2 monitors, one looking from below, another looking from above. And in multiple large stones, staghorn stones, stones in multiple calyces, you put in a flexible ureteroscope from below, you put a mini nephroscope from above, and you can bring down all the stone fragments, stones, small stones in different calyces in the pelvis, and with a single mini tract, you can clear all the stones, what has been called the passing the ball, and you can achieve good clearance quickly and bloodlessly, minimum number of tracts, minimum radiation exposure, and under complete low pressure. The most important thing I would re-emphasize here is that the morbidity of closed system working, which Dr. Balagobi also pointed out in flexible ureteroscopy, which we always push under the carpet, is completely eliminated in a ECIRS procedure where you have access from below and above and free drainage and completely low pressure working. So the incidences of postoperative pyrexia, sepsis are near zero in this procedure. And you can achieve, and the time, what would take you with a flexible ureteroscope hours is done in minutes when you have a combined approach like this. And at the end, all you have is a few millimeters, 3 to 4 millimeter incision, which does not even require a suture. And the patient has a band-aid on the side and he goes home the next morning. In ECIRS, we put a double J stent, but in a mini perc, where you are not manipulating the ureter, you don't even put a stent, you just leave a ureteric catheter, which comes out the next morning. Here, in ECIRS, you put a double J stent, which comes out after a week. So the patient requires only one visit for a stent removal, and we've actually done one up. We sometimes leave a double J stent from above with a string attached coming out from here, with an anti-grade string, which also we published. So you can take it out in the office from here, and the patient doesn't require a cystoscopy. So this, to my mind, is one of the best ways of working on large volume stones anywhere in the urinary tract efficiently and at a fairly reasonable cost with minimum morbidity. So there are multiple benefits of supine PCNL and flexible ureteroscopy combined, which mini ECIRS offers. There are some limitations of supine PCNL which are only technical, and most of them can be overcome with just a little bit of experience. Whenever anyone switches from prone to supine perc, these are the minor things that he faces, he or she, but you can get around to all this very quickly and in no time. And I'm happy to see that many of our colleagues, many are actually switching from prone to supine percs anyway. Some of our publications, this is one on upper ureteric, large impacted upper ureteric stones. There are other publications around the world on combined upper ureteric and renal calculi, large volume staghorn kidney stones where ECIRS has been shown to be of great value. So to sum up again, short hospitalization, minimum morbidity, short operating time, low intrarenal pressures, and excellent stone-free rates. So thank you very much for your attention.